My name is Dr. Jason Bronstein. I am the Assistant Professor of Sleep Medicine and Pediatric Pulmonology. So we are a comprehensive program that can tackle any issue related to sleep. Many people think that we're the place children go for sleep studies or CPAP machines, which is true, but newer programs such as ours are situated to be able to diagnose and treat any issue, whether it's respiratory, behavioral, or neurologic. And we can do children at any age from infancy to adulthood. Our patients usually get evaluated by me, the program director, either in person or via video. I've got experience in cross-training in sleep medicine, sleep psychology, pediatric pulmonary, and even in general pediatrics. So if needed, we can perform sleep testing such as diagnostic polysomnography, titration studies, or multiple sleep latency testing, MSLT, which is the test for narcolepsy. If there's a concern a child won't tolerate testing, we can provide special accommodations or a desensitization plan. And sleep disorders have many different treatments. We can administer a behavioral plan, nutritional plan, prescribe medication, or use assistive breathing devices such as CPAP or supplemental oxygen. Depending on the case, we can garner the assistance of various other pediatric specialists, including ENT or otolaryngology, endocrinology, neurology, psychiatry, urology, dentistry, genetics, and even developmental pediatrics. And while we have a lot of fancy specialists and a state-of-the-art laboratory with pediatric trained technicians, the core of the program really is the comprehensive evaluation and personalized treatments. There's no one-size-fits-all for sleep. Everyone has their own circumstances, their own family situation, their own values and goals. So I work to meet the families where they are. This is especially important in children with developmental disabilities or with chronic medical conditions. I sit down with the child and the family. We figure out what the factors are that are in play. I provide a lot of education and participate in shared decision-making. We try to arrive at a holistic multimodal plan for diagnosis and treatment. Most commonly, children come to us because they're having trouble sleeping or feeling tired or having trouble focusing during the day. Of course, there are many different causes to these symptoms, and we evaluate for all of these. Sometimes we even find more than one cause. Obstructive sleep apnea is probably the most common condition that we see. Sometimes the child presents with clear snoring or difficulty breathing in their sleep, and sometimes the diagnosis is more subtle and surprises the parents. We also deal with central sleep apnea and sleep-related hypoxemia or hypoventilation in some patients. Insomnia is also a very common problem, whether it's purely behavioral or if it's combined with other medical or sleep conditions. We can treat it with sleep training, sleep hygiene, advanced behavioral techniques, motivational interviewing, medication, and even cognitive behavioral therapy for insomnia. Nowadays, we're seeing a lot of circadian rhythm disorders, such as delayed sleep phase, where children are staying up all night and then they're unable to wake up in the morning, or they're dozing off during their classes throughout the day. Some children are severely sleepy and may not have an obvious cause, even after being evaluated in other sleep medicine programs. We are uniquely positioned here at the Mount Sinai Kravis Children's Hospital as an academic tertiary care program to evaluate these cases. We perform multiple sleep latency testing, and we can diagnose hypersomnia and narcolepsy. Many of these children would otherwise grow up and typically go over 10 years and 3 specialty referrals without even receiving the proper diagnosis. Other common neurologic conditions that we see include restless limb syndrome and parasomnias, night terrors, nightmares, sleepwalking, periodic limb movements, hypnagogic hallucinations, sleep paralysis, and cataplexy. Everyone knows that enlarged tonsils and adenoids, and sometimes allergies or acid reflux, are the major risk factors for obstructive sleep apnea. We can often use medications or even behavioral treatments for these. And half the time we can actually avoid surgery, although certainly the more severe cases will benefit greatly from surgery. Most neuromuscular conditions, genetic syndromes, and skeletal dysplasias have high risk for sleep apnea. They have hypotonia, or weakness of the muscles in the tongue, palate, and throat, and sometimes even decreased bony passages or small mandibles. And this causes obstruction to the flow of air when they're sleeping. These patients usually require treatment with a CPAP mask and machine, and they receive a large boost to their growth and development. And I would say the fastest rising risk factor in the last decade or two has been obesity. Up to 60% of obese children have obstructive sleep apnea. We are coordinating a childhood obesity program with other specialists here at the hospital in nutrition, cardiology, endocrine, GI, and even bariatric surgery in order to help get them cured. Most of them need CPAP therapy, and I work with them on this intensively in order to achieve improvements in their academic performance by allowing them to breathe and increasing their oxygen levels and sleep quality. There are a lot of medical problems that can be traced back to sleep. For example, there are many cases of ADHD that are exacerbated by or caused by poor sleep. Very commonly sleep apnea, restless leg syndrome can do it, and even behavioral insomnia. Headaches can be caused by insufficient sleep. If they have an inconsistent sleep schedule or even low oxygen levels and sleep disruption from sleep apnea, all of those can contribute to headaches. And oftentimes when we address that, the headaches will resolve. And the last one I'll leave you with is enuresis or bedwetting. This is often caused by obstructive sleep apnea. Adrenaline surges during pauses in breathing make the body produce large amounts of urine. And during sleep, the same adrenaline surges then compel the bladder to contract.